Hello and welcome to the AIDS 2014 Global Village Connect webinar series. This is a series where we'll explore some of the presentations that have been presented as part of the Global Village seminars, and we'll ask our guests exactly what it was that they covered here at AIDS 2014 in Melbourne, Australia. We also invite you to contribute to the conversation, and you can send your questions to us via the chat feature in the WebEx web stream. Now, we'd like to welcome to the program LAUREL SPRAGUE. She is a regional coordinator for the Global Network of People Living with HIV from North America. She's a lecturer in political science at the Eastern Michigan University, and she serves on the steering committee of the US People Living with HIV Caucus and is the vice president of the board of the Zero Project, dedicated to ending HIV criminalisation and fighting stigma and discrimination. She's been on stage recently at a presentation titled Meet the NGO Delegation to the United Nations UNAIDS Programme Coordinating Board. LAUREL SPRAGUE, thank you very much for joining us.
Well, thank you.
LAUREL, the NGO delegation that works with UNAIDS, tell us about this sort of civil society element that UNAIDS takes on board.
Well, UNAIDS is unique among the United Nations organizations in that it has civil society formally represented on its governing board. So the governing board is called the Programme Coordinating Board. It's basically a board of directors, like in any, like we're used to in our nonprofit organizations. And so the way that this has been set up is that we have 10 members of civil society at a time who sit on the PCB, the governing board, and serve as full board members. We are similar to the other members of the board with a slight distinction. So on the governing board are member states of the United Nations, 22 of them at a time. They take turns serving on the board, and there are also representatives of 6 co-sponsor organizations, and those co-sponsor organizations are the other organizations within the United Nations body, like the World Health Organization, I shouldn't even start listing things, the World Food Program, UNICEF, etc., that work together to coordinate their activities relating to HIV and AIDS through UNAIDS. The co-sponsors don't vote, we don't vote, the member states do actually have a vote on the board.
It sounds terribly complex.
I know.
And it, I guess the question is left then, what, from all of this toing and froing with all of these relevant parties all wanting to have a say and wanting to have a go, what actually comes out of all of this?
Well, it's really been interesting, and I'll start with a caveat that I only joined as a formal delegate in January. So part of what I've been doing since January is trying to just pay really close attention to what difference it makes. You know, I'm constantly asking myself, you know,
why do we do this?
Why are we doing this? Because we're each, for the NGO delegates, we're each spending about 10 hours a week, which is a quarter of our time.
Right.
And we're all from civil society organizations that are really perpetually underfunded, and we all do things in our own countries. So we're trying to balance the kind of good we might be able to do with people at home with taking part in global governance. And so I think there's a constant question of trying to make sure that it really is a good use of time. I will say that I believe that the NGO delegation has made a difference in our position on the board. This is something that as I said, I've been trying to work out over the 6 months that I've been there so far, and I do see that things change because of it. But let me actually just turn back to you and make sure that that's actually the question you were asking me.
Well, I often feel that with so many players and a committee so vast that not only deals with politics, it deals with civil society. It's trying to be all things to all people, and at the end of the day, we want to see things that come out the other end that are really making a difference, and that's the question. Is this making a difference?
Yeah, well, I do think it is. You know, I think the fact that UNAIDS is there makes a difference, first of all, because it's a space to coordinate what all of the other UN organizations would be doing or are doing, so that we're not duplicating efforts. But also, it's the one place that we have that really is the holder of best practices. And UNAIDS has been able to make some really strong statements about how gay men and other men who have sex with men really ought to be treated, how people living with HIV ought to be treated. What are the best practices for people who use drugs? They've made strong statements against criminalization of people who use drugs, criminalization of sex workers, criminalization of people living with HIV. So we've had, I think, a voice for human rights in the HIV epidemic that's been able to compile the evidence that demonstrates that really protecting human rights is a best practice for governments to follow. And so I think without UNAIDS, we couldn't do that. Now, UNAIDS does, though, to some extent, what their board tells them to do. And so you're right that there are so many actors and we have so many agendas on the board. So it's even among the civil society delegation, there are 10 of us. We come from 10 different organizations, and we've really strove, if that's a word, we really strive to make sure that the delegates come from different areas of the epidemic. So we're not only regionally diverse, but we have diverse experiences. We work for gender balance. We have generally about half of the delegates are actually living with HIV ourselves. And then we have people who are connected to drug user networks and sex worker networks and the other key population groups. What we have to work with, though, are the 22 member states. And the UN system is built on this idea that member states, the individual countries, determine the course of how the United Nations system works, right? And so the fact that we're actually at the table with them means that we have some ability to influence what happens, but we're constantly working within these broader diplomatic and sometimes not so diplomatic interactions that happen between these different member states. And so what the United States might want is sometimes very similar to what we want, sometimes very different. Sometimes very different to what Switzerland wants, which is sometimes very similar to Australia and sometimes not. And then we've got the African group, which sometimes votes together and sometimes have some disagreements among them. And over the last few years, there's been a bit of a group with Egypt and Iran having some specific ideas about what UNAIDS ought to be doing that are often quite at odds with what the NGO delegation has hoped to see.
I guess it's what ultimately has been wound back in the language as, instead of being a pandemic, it's referred to as a global epidemic. And it's because the nuances in each region are so specific to that region that it is very much a localized response that's required. When we see political engagement that changes, like what we've seen in some of the sub-Saharan African countries, winding back laws around homosexuality and key affected populations, this is where the United Nations has the most power to step in, potentially, and make a difference. And yet we see very little engagement from those countries interacting with the UN as they push forward to make these changes. Let me get your perspective on that.
Well, I think it's very tricky. I think what we all want as advocates and people who care about human rights and dignity and basic safety of other human beings, especially those that we may feel close to, people who are also gay and lesbian, people who are also transgender, people who are drug users, people who are HIV positive, the whole list. What we would love is to have some big group be able to go in and say, you can't treat people this way. We have a Universal Declaration of Human Rights, we have covenants, we have treaties, this shouldn't be happening. And then I think where the challenge comes in is that each of these states are sovereign, and they, to some extent, have the right to determine what happens within their sovereign territory. And to the extent that the United Nations or other global institutions try to step in, they can also lose a bit of legitimacy. And so I think we really need a United Nations system that is seen as very legitimate. And so it's a very difficult tightrope for them to walk, because if they do step too far, then those countries won't listen to them at all. And so I think we're constantly pushing, at least within the UNAIDS program, for very strong statements about how people ought to be treated. To really set the bar that when these laws happen, and it's, we've seen it in Uganda and Nigeria, but we've seen it outside of Africa as well. And we see what's happening in Crimea, we see what's happening in Russia, we see what's happening around criminalization in North America and the Nordic countries, as well as Australia. So we have these really challenging situations around human rights that we're really pushing for strong attention to, and yet understanding that we'll push as hard as we can, but there is going to be a bit of a diplomatic path that the UN folks are going to take.
Our guest on AIDS 2014 Global Village WebEx, Global Village Connect's WebEx webinar series is LAUREL SPRAGUE from the USA. She is part of the NGO Delegation to the United Nations UNAIDS Programme Coordinating Board. And Laurel, your particular focus in the US around HIV and AIDS in the US, it's a very, how do I describe it sensitively? It plays out racially in the US, like it doesn't play out racially here, perhaps to the same extent. Here in Australia, we're very much gay men who have sex with men focused issue regarding HIV. In the US, it's very different. How is the US going to challenge or tackle this particular challenge?
Around the racial disparities that we see.
Yeah.
Well, what's really clear in the U.S. is that every group of people that has been marginalized economically and politically or socially,
they're on the list.
They're on the list.
Right.
They're disproportionately hit with HIV, and it's no coincidence. I think that there are so many levels of challenge. We're talking in the U.S. and in many other countries as well, but certainly in the U.S. about people who have really good reason not to trust public health, who have really good reason not to trust the police, historically. And so when we are now, so then we get, not just now, but over 30 years, this epidemic comes out. And I think it's very difficult for people to know who to trust to get good information. Because historically, these, public health authorities are seen as agents of the government and have acted as agents of the government and not in the best interest of African Americans or Latinos or Native Americans or gay people, poor people in general. And so it's really complicated that way.
But 30 years on from this epidemic, taking hold, it's kind of frustrating that we're even having these conversations, and it must be, for someone working so closely in the US in this sector, it must be infuriating. How do you get up every day?
But you know what else is infuriating? It's not just HIV. It's that we're still having these issues around racism that we haven't resolved.
Yeah.
And that's more than 30 years.
Sure.
And the issues around poverty. Even in the 60s when we were talking about having, a war on poverty and turned into a war on poor people, right?
Yeah.
Or having, a civil rights movement that was really effective, and yet at the same time didn't change any of the underlying economic conditions that shape people's lives, and in many ways kept many racial prejudices and racialized biased, discriminatory systems in place. So it's ridiculous. But I think, I guess it could be infuriating. But honestly, I believe that we're always in a struggle. This is that as soon as we figure out how to address the current struggle we're in, there's going to be another one. It's not like we're just going to figure out how to liberate one group of people and we'll all be liberated and everything will be fine. So I guess I think it's all in a day's work. So it's wrong that this still exists, but I think we're naive to think that we're going to overturn these large systems quickly. I think we have to work from the grassroots up to make the kind of societies that we want to live in.
One of the things that I know that you've been working on as part of your, I guess, remit in the US is criminalisation.
Right.
We've had here in Australia, and particularly here in this state, in Victoria, the host state of AIDS 2014, we have a law that is specific to HIV, and that law has meant that it's segregated, it is marginalised, it is targeted, and that reinforces the stigma around the issue, and it plays out in all sorts of ways. You've recently had a bit of a win in the US regarding this issue. Can you take us through that?
Right. Well, you're talking about the state of Iowa, which had really the harshest law in the entire country. People were being sentenced for consensual sex between adults with no transmission to 25 years in prison and lifetime sex offender registry requirements. The level of injustice was just horrifying. And in Iowa, like many states, it seems to be clear that if a person living with HIV is alleged to have done anything wrong, including not disclosing their HIV status to a partner, whether they did or not, they really haven't had a chance in the court system. So there's been a really terrific movement in Iowa, led by people living with HIV and also people living with HIV co-infected with hepatitis, to try to remove that law, to change and remove that law. And they had a champion in the state Senate, Senator Matt McCoy, who listened and took up the cause. They built a coalition of 20 or 30 statewide groups and went deep into the political abyss as the senators and then the representatives in the House of Representatives talked and debated over how they might change the law. And they had to make a lot of sacrifices and negotiations, and what ended up happening is that they got the law reformed, which is absolutely amazing. They got people off the sex offender list, including retroactively. People are coming out of prison, which is remarkable. At the same time, the law isn't perfect, and so there's still I think everyone's gearing up for the next stage to make sure that people don't continue to be incarcerated unjustly, and there's still the potential for that.
Well, we're now joined here on the AIDS 2014 Global Village, well, we were joined, he's now just leaving us. John Rock is also on the NGO Delegation to the UNAIDS Programme Coordinating Board, and John is part of the International Treatment Preparedness Coalition, consulting with the UNAIDS Programme Coordinating Board. John, thank you very much for joining us today. John, it is, yes, John. Hi, how are you?
Good to be here. Thanks very much.
John, thank you for being a part of this conversation. You've got a particular interest in getting the UNAIDS to take a part in intellectual property around diagnostics and medication. Would you like to talk to us about why it is that intellectual property is getting in the way of the HIV response?
Okay. So going back to the time before patents were on pharmaceuticals were part of the World Trade Organization, there was pretty free access, but the World Trade Organization introduced patents on pharmaceuticals, and in so doing it recognized that potentially that was going to cause some problems in developing countries in terms of affordability. So in so doing, they introduced something that was called TRIPS flexibilities. What that allowed was countries to issue compulsory licenses for essential medicines and effectively to be able to get access to generic copies of these medicines and thus break patents. And there was something called the Doha Declaration which reaffirmed this right. But since then what has happened is that many of the developed countries with pharmaceutical lobbyists have included in their free trade agreements a number of what are called TRIPS Plus clauses, which basically take away those rights. So effectively, the United States, the European Union, Switzerland and Japan are the main people who have intellectual property around patents of pharmaceuticals, and they are the ones that are introducing these TRIPS Plus clauses. At the moment, Australia is in the middle of negotiations on the Trans-Pacific Partnership, which is said to be the free trade agreement to end all free trade agreements, and there has been some discussion in Australia about this. It's been going on for a number of years. It involves the United States, which is the net exporter of intellectual property and the one leading these TRIPS Plus clauses, and the other people are Canada, Mexico, Peru, Chile, New Zealand, Australia, Brunei, Singapore, Malaysia and Vietnam. What happens basically as a result of these free trade agreements is that countries lose the right to issue these compulsory licenses. Now, it's a very, very complex area and there are other barriers as well. But suffice it to say that the first-line regimens generally are off patent, except for some of the better first-line regimens, and that's why they're inexpensive. and they have been available in generic form, and partly historically this was because the Indian generic companies, and Cipla in particular, led the prices down in about 2000. Since then, a lot of these have come off patent anyway, but the difficulty is that the best first-line regimens, which have got less side effects and are more robust, are on patent in a lot of countries, and the second and third line are on patent in virtually all countries, those who are signatories to the World Trade Organization. So we end up with a situation whereby no matter how adherent people are, some will need to go on to second and third line. And for those people who aren't adherent for whatever reasons, and it's very easy to condemn people who are not adherent, but actually it happens in a social context and that's quite complex, are going to need to move to second and third line. And the fact of the matter is that these drugs are very important. Now, there have been a number of attempts to try to address this through voluntary licenses, which have tended to favour the least developed countries but put pressure on the middle income countries.
I guess, John, my question is, what on earth can the United Nations do in this space, and what is it that you're, as part of the NGO delegation working with them, what is it that you're pushing them to do?
Well, you know, it's first of all, let me say, it's not just HIV drugs. And diagnostics, should I say, because diagnostics are a very important part in.
And we've seen this in breast cancer and all sorts of things.
Exactly. So it's non-communicable diseases. It's diabetes. It's heart disease. It's cancers. It's hepatitis C. It's TB.
It's just genetic coding and things as well, isn't it?
Well, that's another issue as well.
Right.
Yes. On top of the problems. So, in a sense, the spirit of the problem that the World Trade Organization recognised has not been upheld by these countries negotiating these free trade agreements. And we've probably got to the stage where we could try to stop more free trade agreements, and that can be done perhaps in terms of countries considering very carefully their patent law and the criteria of patentability. I mean, we see that Argentina changed its patent law a year or so ago. We see that South Africa is thinking about changing it. India has very high criteria of patentability, which is why the generic industry was able to thrive. So there are things that can be done there. There can be advocacy around opposition to free trade agreements. But fundamentally, what I think is required is that we need a different paradigm. And
it's interesting you say that India has a higher level of criteria. India, by Western countries, and I use that term generically, US, Australia, was criticised as being open, free-for-all, open slather. You're saying they have a higher level of criteria for them to protect the patent. Can you explain that paradigm for me?
No, to get the patent.
Right,
not to protect the patent.
Okay.
So in other words, let's say, for the sake of argument, you decide that you want to make a tablet form of something that was available as a capsule. The Indian would say there's nothing new in doing that. Everybody knows that tablets can be made instead of capsules. Or they would have a look at a particular molecule and say, fundamentally this is the same molecule, all you've done is to tweak this, or all you've done is to make it bioavailable. Basically it's much harder to get a patent in India. And in fact, we see that there was a huge issue a few years ago where Novartis had applied for the patent with Gleevec, a breast cancer drug, and it was refused in India, and Novartis went as far as it could through the court system in India to try to show that the Indian patent law was unconstitutional, and they failed.
And yet it's demonised by countries like America and Australia, their system, but you're saying it's a better system.
Well, I'm not sure that it's demonised by Australia. Certainly it's demonised by the United States. But on the other hand, the United States is a net exporter of intellectual property, and it has an absolutely huge pharmaceutical lobby. And
they're very powerful.
They're very rich as well.
Yes. So coming back to the question of the United Nations.
So what could UNAIDS do? Well, I mean, I think that UNAIDS can lead a dialogue about whether the current system is indeed serving the interests of world health. And it's not just UNAIDS, but I think that when we see the SDGs playing out after 2015, then access to medicines for a variety of health conditions are going to be important. But I think that UNAIDS is able to take a leadership position in this. So the NGO delegation, bearing in mind, of course, that in the final event it's member states who are members of the World Trade Organization and who would vote on issues around a different paradigm. We would hope that UNAIDS might work in creating awareness amongst the member states of what some of the options are and what some of the issues are. I mean, the trouble is that community is not well funded to be able to create this awareness, and it's a very complex area. Yet the pharmaceutical industry, of course, has very large resources at its disposal to fight such things.
Our guests are Laurel Sprague from the US and John Rock from Sydney, Australia. We are talking about the NGO delegation to UNAIDS and the Programme Coordinating Board. You are on a Global Village Connect webinar series for AIDS 2014. My name is Dean Beck. John, ultimately, if these patents, they are about companies making money, those companies then introduce the latest technology, they have the latest breakthroughs, they can invest in getting perhaps the cure. How are they supposed to be able to invest in these developing issues and developing technologies if we're not paying our way for them?
Well, again, if you're going to have a look at a different paradigm for intellectual property, then you've also perhaps got to look at a different paradigm as to how you pay for research. However, let me say that a lot of the drugs that are used in treating HIV at the moment were actually not completely developed by the pharmaceutical industry itself. I mean, the classic one, of course, is AZT, which was developed as a liver cancer drug. And there are many other examples where the molecule was developed somewhere else, or it was developed. There was one that was developed by NIH in the United States, and
there's also been, I guess, the flow on too that whatever they've developed with HIV being the focus, they've realised doesn't work, but it might work for something else, and they've been able to profit from that too.
Potentially, but I think the other issue is that the pharmaceutical industry has talked about the huge amount of money that it costs to bring something to market, but actually that has never been tabled in a way which it can be verified.
Right.
Interesting. It's
a good argument on the surface, but show us the figures.
Well, that's right. That's right.
Laurel, this plays out in all sorts of ways for people who are living with HIV, and ultimately it's about access to medication and treatment, and access and compliance, two of the most vital things if we are to stop the transference of HIV. We were talking earlier about the way it plays out racially in the US, but also in the US, the health system itself is a costly exercise. Tell us about how you get treatment to people that need it when it costs so much just to have a day in hospital.
Well, the U.S., as you know, we're in a transition period with the Affordable Care Act.
You've got a long way to go, I would suggest.
We've got a long way to go. But what we do have are people who have health insurance now. When there was such a large portion of our country that has not had health insurance or any guarantee of health insurance. So I think we will see changes. We certainly saw changes in Massachusetts, which is really the model for the Affordable Care Act that we have now nationwide. But the way that the Affordable Care Act was ultimately negotiated meant that we still all get our care through private insurance, or we all get insured through private insurers, and then we get our care, and it's all managed through private insurance companies, which hasn't brought the cost down at all.
No,
there's no single payer system. There's no ability to negotiate prices.
Someone's paying the bills.
Right, and it's us.
Yeah.
More or less. We find basically the costs are passed on to the citizens and the people in the United States. So it is difficult. People with HIV have long had a separate route for accessing care, so getting care with the same doctors in the same hospitals, but we've had a federal program that gets channeled through the states called the Ryan White Care. That's through the Ryan White Care Act. So we get Ryan White money, federal dollars, that are used to help cover the cost of treatment for people living with HIV and care for people living with HIV. And a lot of us get some kind of support through the Ryan White Care Act. So it goes to help pay drug costs, the cost of medications that even when you have insurance, often the kinds of copays that we face make it completely unaffordable to still have medications. The copays can make it completely unaffordable to go see a doctor. And so right now we have this program that we're always hoping will be reauthorized and maintained, strengthened in fact, to cover the gap between what our insurance will cover and what actually the cost of treatment and care is.
John Rock, it's one thing for us to be having this conversation in wealthy countries like Australia and the US, but the UNAIDS has to look at a global issue around medications and treatments, and I guess intellectual property gets in the way of countries that are much poorer than our own.
Well, this is right. I mean, we pay large amounts of money in Australia, but on the other hand, we're a relatively wealthy country. I mean, I thank the Australian taxpayer for funding $30,000 towards my own medication costs. It's very kind of them. But the real issue is in developing countries. In a lot of the low-income countries, there have been deals on pricing that have been cut, which have helped somewhat. It has been an awful lot harder to get good deals on pricing in middle-income countries, and one suspects, or one might if one was cynical, that the pharmaceutical industry would write off the low-income countries as not being able to afford the prices that they would like to charge, whereas if they squeeze the middle-income countries, perhaps they are. The point that we always make is that access to sustainable, affordable, good, effective medication should be a right for everybody wherever they live, and it shouldn't depend either on the GDP per capita of the country in which you happen to live, or just by geography where you're situated.
Well, let's get a little controversial. Should that right be afforded to people who slip up, and should that right be afforded to people who are negative? And by that I'm talking about pre- and post-exposure prophylaxis, the cost of that to government.
Yeah. Look, let me take the second one first, okay. the pre-exposure prophylaxis. I think that you'd have to look at that on its merits. So, for example, a sex worker who may have difficulty in negotiating safe sex with a client would fall perhaps in a different category to a man having sex with other men who just doesn't like condoms and has a lot of sexual encounters. Yes, indeed, and I think there would be a lot of countries who would be wondering about that.
But who makes that value judgment?
Well, what I would say is that in any case, whilst there are people who are living with HIV who can't get access to treatment, the morality of giving it to people who are not sick has to be questioned. So you're not going to get an argument from me on that.
Okay.
A lot of my positive colleagues may think differently, so I'm expressing a personal view.
I understand that. Laurel Sprague, what's your point on this? Surely stopping the transference of HIV longer term is going to be better for health systems and outcomes for individuals than the Russian roulette of let's see how we go. Yeah.
Well, absolutely. I mean, one of the things that makes me absolutely enraged, I have to say, is that we have no global triage system for making sure that all the people who need medication can get it. You know, I think that, you know, it's just absolutely frustrating that we have extra medication for anyone who needs it and can pay for it in wealthy countries, you know, and that we don't have enough to just keep people alive, that people are getting tested with CD4s of 50, you know, under 200, you know, and there's a whole other reasons for why people aren't being tested sooner, but then we're not making available treatment that people need just to stay alive. And John and I are both people who have been very close to death and are only alive now because treatments came out and we, by some good stroke of fortune, happened to scratch our way through until those medications showed up. And so, you know, dying doesn't look any different now than it did, you know, 20 some years ago, and nobody wants to leave their children. You know, nobody wants to go through that, especially when medications are available. So that's the first thing. Is it just frustrates me to no end that we can't make medication available, or that we have not made medication available to just keep people alive. You know, having said that, if we are going to have medication and have the ability to make it available, I mean, first of all, I think that the price point that we see now is absolutely false in terms of what it actually costs to research and manufacture these drugs. So in some ways, we're getting this artificial.
But you would say that. I mean, let's put on the hat of the pharmaceutical company. They would say, you know, that it's cost a fortune, as John said, and we can talk about whether show us your books.
Right.
But but then they would also say, if you want us to invest in the latest and the greatest, we need to be able to afford to pay that.
Well, and I think we'd believe them better if they didn't make the kind of exorbitant salaries they make, if they didn't have the kind of bonuses, the kind of PR. You know, I think that it's really hard to believe their claim when you see sort of the lavish lifestyle payments, etc., that happen there.
They're paying in part for this conference that we are currently at right this very moment.
Right.
So is that part of their is that guilt money? What is that?
You know, I don't know. I don't really care, honestly. No, I'm sorry. That's not the question I really care to answer because I don't know. I don't know what's in their hearts.
Sure.
I will say I'm extremely grateful that people, for whatever motivation they had, got their brains together in the right space and the right time and came up with medications to keep people alive. And I don't want that to stop. I'm not against innovation. I'm not against research. I'm not against even people making a profit. What I am against is setting the price point so high that we're having these fights about who ought to be able to stay alive and who's expendable. And I think that's a real ethical challenge that the pharmaceutical industry has not, for the most part, been willing to face up to. That this capitalist model has seen, has been held up as, essentially the right way to do things without ever really having these kinds of conversations.
There has, John, been a shift, though, in and let's be clear, they were forced to do so, but in pharmaceutical companies lowering prices to certain countries to ensure that they did have access. But this global triage idea, which I love that term, that Laurel has suggested, it's not implemented, and there are countries that just do not have access, and people are continuing to die. How do we change that?
Well, this is exactly what we're trying to investigate. And let me say, to go back to an earlier point, of course, big pharma, as we call them, need to be involved in getting sustainable, affordable, effective medicines to people. It's going to require a lot of cooperation. But the system that we have at the moment isn't really serving us. This is the problem. How do we address the question of affordable medicines? Well, I think that we have to have a dialogue. I mean, there have been recommendations that we need to look at a different paradigm. I think we should look at a different paradigm. Different people will have different ideas of what that might be. But the fact of the matter is that at the moment it's not working. And the issue is that return on investment is fine, and that's one lens that you look through a product, but we're not talking about washing machines, because there's another lens that you could look through which says this is the difference between me living and dying. So
there's also, I guess, quantifying the loss, the cost of the loss, both, and if you want to talk about intellectual property, let's talk about that, the brains that we've lost, and the inspiration that we've lost. You can't put a price on that, surely.
Well, I think the other thing about it is that getting treatment to people is important, first of all, because it avoids them falling out of the work system. It keeps them productive, they pay taxes, they are not a burden to the healthcare system, and we know that if you get people onto treatment, it reduces their infectiousness. So there's a very good cost-benefit argument to both the individual and to society.
How do we globalise that?
Well, this is something that maybe has to be done with a global body, which is why, hello, we're back again with the UN, we're back again with UNAIDS. Nice question.
So I guess, John, you've been working with the NGO delegation to the UNAIDS for quite some time, I believe. How much of it is just to keep the sector quiet, and how much of it is actually UNAIDS delivering what the NGO delegation are pushing for? How much do they listen is the question.
Look, they do listen.
Okay.
There's no doubt that they listen. But you know, in a body like the UN, where you have member states who basically make up the UN, things aren't always as straightforward as going out and doing it if you're running a large corporation. So you have to recognise that you're working with a diversity of nations with all sorts of different perspectives on it. Does that
become frustrating, from your point of view, who's contributing to this?
Sometimes it can be very frustrating and very challenging. But you know, I think that UNAIDS is the only body that can influence what happens in a global sense. It is a global forum. We have sitting around the table countries from all regions of the world, and I think that they are the best mechanism to be able to do this, and I think that we have to work with them to be able to try to reach those goals.
As we draw this session to a close, I'd like to get from both of you your thoughts on AIDS 2014, your experience thus far. It's really only getting going, but Laurel Sprague, tell us, you've been to some of these before. How is AIDS 2014 shaping up for you?
Well, it's shaping up as a whirlwind, which I think is the case for most of us. It's hard to have a sense, I think, until about 2 weeks after the conference when you figure out what really happened. I think it's really marked by the deaths of colleagues that were en route when they were shot down. I think the war and suffering of people in Ukraine really was brought home, as well as our own losses. I think every one of these conferences reminds me again of people who are gone, as you just said, I think so well, what we've lost in terms of the brilliance and commitment and ideas and innovation and just love, the generation of gay men that we don't have, that would have been mentoring so many young people. You know, I mean, all of that comes home. What I think is really interesting to me, and it reflects the kind of work I do, one is the Indigenous presence here. I think that the Indigenous Networking Zone has an incredible program, and they've done just a lot of work to bring the issues of Indigenous people related to HIV and make them more visible. It's a group that's persistently invisible and really deserves the kind of attention that they've had to fight for. The other thing that, from a social justice lens, is notable to me is the focus on criminalization within communities. That we really are seeing broad movements from multiple countries and regions in the world coming together to figure out how we can protect one another and fight these unjust laws. So I think that is something that's really a movement that's starting to boil and move forward, and that's going to be really picking up steam here and then taking off further.
John Rock, for us to be hosting AIDS 2014 here in Australia, it's a tremendous privilege. Tell us what you hope that will be the lasting legacy for our nation to be the host of this for this conference.
It wouldn't have been my choice.
Tell us why.
Because it's too expensive to get here, and I question the value of having AIDS conferences every 2 years. You know, what affects the lives of people living with HIV is what their governments do, the extent to which they're prepared to step up to the plate, the extent to which they're prepared to change laws, the extent to which they're prepared to make a real effort to address stigma and discrimination, the extent to which their country coordinating mechanisms will include treatment and virtually everything, right?
But it's hard to dismiss the level to which this country has stepped up in the last 6 months. They have moved in leaps and bounds to prepare for this conference. Things like waiting a decade for rapid HIV testing is inexcusable, and we now have it. Surely that's got to be the lasting legacy for us as a nation.
Yes, I wouldn't deny that, but I often wonder whether we might not get more use if Tony Abbott were to use his abilities to talk to some of the neighbours who could more usefully follow the Australian model, a little bit like Michael Kirby suggested yesterday, because in the final event here we're preaching to the choir, and it's a very expensive way of preaching to the choir, I think.
John Rock, thank you very much for joining us on this AIDS 2014 Global Village webinar, and to you, Laurel Sprague, good luck with the rest of your AIDS 2014 journey, and thank you very much for joining us today.
Well, thank you very much.
My name is Dean Beck. We hopefully will get you to join us for some of the other webinars that are coming up over the coming days here at AIDS 2014. Thanks for being with us.